is like a neurological toxicity. So in the BMT patients. So objective of this class, like we'll see like what is a severe neurological event, and we'll see what are the signs and symptoms will be there in a neurological event. What are all the risk factors will be there, and we'll see nursing interventions. Generally the incidents of like the major incidents are like will happen due to infection, and sometimes due to GVHD and SOS, and severe neurological events will be there. So more we'll see in our, especially like I'm not taking only thalassemia patient, overall population I'm taking, like infection is the major cause for neurological events, and GVHD and SOS. The definition is an alteration in neurological status or function that is life-threatening or medically significant, disabling, limiting self-care, or prolonging hospitalization. So usually the symptoms, the patient start with a headache, severe headache, patient will have tremor, and facial deficit will be there, confusion, hallucination, sometimes more time we have seen seizures, and altered level of consciousness will be there, and everyone knows the press, like posterior reversible encephalopathy syndrome. So usually the 20% of patients in a more popular like an allogenic transplant, and it will be the common issue, and autologous is uncommon. Significancy, like there will be mortality and morbidity, both things are there. So the time distribution and type of severe neurologic events, like first year after HPCT. So more about the immunosuppression induced. So immunosuppression induced, we have seen like cyclosporine, so tacrolimus that will be there, and some cases like radiation induced hemorrhages will be there, like due to patient platelet low and hypertension, there is a chance of getting hemorrhages, immune mediated, and infection induced. The risk factors are like age, underlying diseases, prior treatment, condition regimen, which condition regimen we have used, HPC source what we have used, GVHD, immunosuppressant, metabolic disorder, and then central nervous system infections. So these are the risk factors. So younger children will be high risk for this thing. And vulnerability, the total body irradiation, the patient who is getting total body irradiation generally like less than 2 years, so there will be high risk of getting the thing. Also underlying disease like leukemia, solid tumor in these conditions, like central nervous system involvement and diagnosis and recurrence will be there. Brain tumor, central nervous system issues like neurocognitive defects. Sickle cell patients will have this high risk, and metabolic disorder, so the such patients will have encephalopathy. So this all the some of the medication which will lead to things are like vincristine, patient who's receiving vincristine, asmoproxine, ifosfamide, cyclophosphamide, melphalan, and methotrexate. So generally in our cases, more will use methotrexate will use and cyclophosphamides will use. So in this case here, like high risk are like a SIADH will be there, and neurocognitive defect and encephalopathies will be there. So chemo regimen ways like busulfan, there is a high risk of seizures will be there. Cyclophosphamide will lead to seizures. Carboplatin, fludarabine, cetrabine, and steroid. So generally in our cases, again, we are using busulfan, we are using cyclophosphamides regularly, we are using fludarabine, we are using, and steroids we are using. So there is a high risk for like seizures and confusion, visual disturbance, and psychosis will be there in this one. Also radiation and methotrexate, so ATG, so this also will have the neurological events. So due to ATG, there is a high chance of like viral encephalopathies will be there. Again, ATG, if we use a high dose of ATG, what we are using is not much thing. So in high dose of ATG, there will be chance of getting viral encephalopathies. So cumulative risk factors are reported like autologous transplant, like 2.4 related donor 15% and unrelated donor as 38% as reported. So in acute GVHD, generally we'll be using high dose of steroids, and there'll be high BP, and there's a chance of getting acute intracranial hemorrhages. And chronic GVHD, in chronic GVHD, like peripheral neuropathy will be there, immune mediated interventions will be there. So immunosuppressant agents which we are using, tacrolimus and cyclosporine. So this chart will explain what are the issues will be having the by using cyclosporine. Patient may get tremor, confusion, press. So due to tacrolimus also patient may get press, and cyclosporine also patient will get press. So these are the issues patient will go to due to the immunosuppressants. Acute mental status changes will be there in generally due to cyclosporine and cycloramus. So in the MRI, we'll find the white matter changes and cortical ischemic we'll see. Differential diagnosis TTP and hemorrhage on CT scan we can see decreased dose of due to that time usually when the patient will get toxicity of the cyclosporine type of thing. So we'll reduce the dose and we'll stop the dose, and we'll change for alternative like MMF, like that we'll change the medication. So due to toxic metabolic encephalopathy, so global brain dysfunction associated with the drug toxicity, electrolyte abnormalities will be there, organ failures may happen, infection, no conversion of seizures will be there, acute GVHD, 6% of patient, 1 of the pediatric patient serious will be there. Risk factors, again, age, older patient will high risk for encephalopathy. So chemotherapy like busulfan, cyclosporine, so imipenem, so renal insufficiency, liver failure, viral infections. So these all things will be high risk for the encephalopathy. Clinical presentation, altered sensorium, patient will be not confused, lethargy will be there, focal neurological sense will be there, and hemiplegia will be there, chances are there. Encephalopathy diagnosis, MRI will do, encephalogram, EEG we can do, and CSF studies they will do, and last part like brain biopsy, that's a very complicated thing. And management discontinue the implicated medications. What are the medications is implicating to encephalopathy that has to be discontinued? Correct the metabolic disturbance and treat the underlying infections and seizures. So central nervous system infections. So generally the other central nervous system infections also lead to neurological toxicity. So viral infections, HSV, HHV6, VZV and BK virus, adenovirus and CMV, and fungal aspergillus also will lead to neurological issues. Risk factor, again, allogenic HPCT, unrelated donor, prolonged immunosuppressions will be the risk factor. Presentation, patient will have fever, headache, confusion will be there. Diagnosis, like we may do the cultures, PCR studies, imaging, this all the requirement will be there. And treatment, empiric and specific pharmacology agent we may use. So if prone fungal is there, means we have to use antifungal, antiviral, like we have to use. So anatomy and physiologic correlations are like cerebral vascular events will be there, toxic metabolic encephalopathy, press, seizures, CNV infection, proximal muscle atrophy, and chronic leukoencephalopathy. Cerebral vascular events are like types intracranial hemorrhages, stroke, subdural hematoma will be there, ischemic stroke. Risk factor, again, thrombocytopenia, like maximum our patients will be have low platelet, neutrophil recovery, immunosuppressive medications, vascular injury, vascular occlusion, and fungal infections will be risk factor. Diagnosis for this also like coagulation professors will do CT and MRI. Treatment, correct the coagulopathy, transfusions, treat hypertension, seizures prophylaxis, management, increase intracranial pressures, neurological consultation, and treat the underlying infections. Press. So press maximum, like many of the in a lot of things we have seen, like and everyone have seen this one, headache. Generally, the before the episode of the thing, patient will complain of headache, slightly altered consciousness will be there, and patient will get seizures, cortical blindness, and paralysis will be there. Diagnosis, again, CT and MRI we can do. MRI is the best thing. Management, antihypertensive, we have to control the blood pressure of the patient. Correction of metabolic disturbance, and adjust the immunosuppressant agents. So we have to check if patient is on cyclosporine, we have to change the stop that one and we have to put it in another like MMF thing. She's risk factors are like medication like busulfan, cyclosporine, again cyclophosphamide is other medications something. Pressure station, general tonic or chronic conversion will be there. Prevention and management are monitor the medication level. So busulfan levels we are not doing, but cyclosporine levels generally like weekly once, weekly twice we see. If levels are high, we have to reduce the dose and we have to monitor very closely. Blood pressure monitoring is very important. Proximal muscle atrophy, clinical presentation in that one, like muscle weakness will be there for patient, muscle pain, patient will complain of frequent muscle pain, and functional impairment will be there. Risk factors again, carditis, somebody who's getting steroids and chronic GVHD. So these are the risk factors are there. Management like nutrition, exercise, physiotherapy, and treatment of chronic GVHD. Acute irreversible and chronic leukoencephalopathy. So again, in here, like clinical presentation, progressive acute mental deterioration lasting for more than 2 weeks, confusion, altered mental status, abnormality, movement and abnormal movement and seizures will be there. Risk factor again, CNS irradiation, systemic intrathecal methotrexate, cyclosporine, and JC virus will be there. Diagnosis again, MRI will be there. Supportive care, outcome generally unfavorable in this condition. So main nursing interventions are like for this all over the neurological events are. So regular vital monitoring is very important. So as we've seen, like the blood pressure especially is very important. The hypertension will lead to a lot of neurological events. Level of consciousness. So patient level of consciousness, like the Glasgow Coma scale, we have to see like patient movement, everything, and pupils, both pupils are reactive. So that is very important. And gross motor activity, extraocular movement, and vision. So these all the things, the neurological assessments are very important. So mental status examination, and if patient is compared like severe headache or vomiting, headache with the vomiting is there means generally in the neurological issues, the patient will complain more about headache and vomiting, frequent vomiting will be there. In that case, we have to take it seriously, we have to inform. And speech impairment, anything is there, and extensive motor observations to see. So again, seizures thing, if patient gets a seizures or anything, like we have to head drop, I have to do, and the lateral position we have to see, and like patient should not get bait. So this other thing like seizures management are very important. We have to put a patient on the lateral position, oxygen administration, and seizures control medications are very important. Nursing management again ensures safety and transfusion blood components. Usually, generally, patients are platelets are low, regular transfusions are required, and PCV and proper prepare for diagnostic test if anything is required. Obtain laboratory tests like coagulation profiles and platelets is all things immediately to collect. Administered medication, anticonvulsant medication regularly patient has to receive, antihypertensive, electrolyte balance we have to maintain, and immunosuppressant. No drug and dietary interactions. So any drug interactions are there, and that has to check and reassure the patient and educate the patient. Laboratory studies, again, drug levels, cyclosporine levels are very important, and biochemistry levels and cultures in the, and blood counts are very important. And CT and MRI, as we discussed, that we'll see in the maximum in all the neurological events. Sometimes there may be requirement of lumbar puncture and EEG, and the regular consultant with the neurological neurosurgery department. So sometimes the patient may need ICU. So probably like to require the patient to ICU if the patient's conscious levels are going severe down and continuous seizures, or the patient has continuous seizures. In these conditions, like patient may need ICU care also. And then ICU care also, like stabilizing the patient, detailed handover. So when we are shifting the patient from BMT to ICU, so the detailed complete handover is very important, more about the hypertension and immunosuppression medications. So this and support with the patient family. The patient family will be going a lot of psychological issues. So that support is very important. So in the neurological event, there's a lot of chance of morbidity and mortality will be there. So high risk factors are there. So generally, like we can prevent this, many of the things we can prevent and recognize. Early recognizations are very important, and we have to treat at cost. Thank you.
Thank you, Sandeep.
Thanks, sir.
Yeah, I just want to, any questions or comments?
For me, it's okay in the presentation. Thank you.
Okay. Okay, Sandeep, I just want to make a remark on busulfan. So, as you know, we have actually never seen, as far as I remember, we have never seen a seizure during busulfan administration. And that's another reason why we don't measure levels, because we really wouldn't
Yes, sir.
know how to improve on because we don't give a full dose of busulfan. Actually, we give 14 milligram per kilo, and levetiracetam we used to use lorazepam, but as you know, that was causing paradoxical hyperactivity, agitation, and so with levetiracetam actually we're quite successful. So most of the time when we see a seizure, practically speaking, is either a bleed or press. That's the sort of
Yes,
the
sir.
number, the two main things that we see. Yeah. Okay. So if there are no other comments, Azra, do you want to